because we come from communities where the truth doesn't always reach the headlines, but it lives in what we face every day. This is Changing Trends and Times, bringing clarity and context to the issues shaping our lives right now. No spin, no distractions, just real talk rooted in real impact. Now, are you ready to lean in and bring your voices into the conversation? Then, allow me to introduce to you a man committed to asking the questions that matter and breaking it down so we all understand. Your host, Charles.
Good afternoon, ladies and gentlemen, and welcome to another episode of Changing Trends and Times, where today we will be doing part 3 of our medical series, that is healthcare in the underserved communities. Today's topic is the systemic barriers to care, that is race, economics, geography, and institutional neglect. First of all, I want to thank each and every last one of you that are here right now. I appreciate you for taking time out your busy day for being here. And what I want to do first is I want to give you guys a reflection first as we go into this, and that is just talking about, well, actually, it's my monologue that's going to tell us about healthcare and what we historically have had to go through. Picture a woman somewhere in rural Mississippi who woke up this morning with chest pain. She is not calling 911. She is calculating. The nearest emergency room is 90 minutes away. She cannot miss work because she has no paid sick leave, and missing a shift means the rent does not get paid. She has insurance, technically, but the deductible is so high she has not used it in 3 years. So she sits with the chest pain. She manages it. She awaits. And somewhere in that waiting, the window for the best possible outcome quietly closes. Picture a man in a city, this time Chicago's South Side or Baltimore or Detroit, who picked up his blood pressure prescription last month and then looked at his bank account. The copay was $40. $40 he did not have after the electric bill, so the prescription sits unfilled on the counter. His blood pressure is unmanaged, not because he does not care about his health, because caring about his health has a price tag he cannot meet. Picture a child 8 years old, struggling in school, falling behind her peers, whose teacher suspects a learning disability. But her school district, chronically underfunded, does not have a school psychologist on staff, and her family, uninsured, cannot afford a private evaluation. So she moves through the grades labeled as a behavior problem instead of a child with an undiagnosed and treatable condition, a child whose trajectory was altered, not by her capacity, but by a system that could not see her. These are not tragedies or bad luck. They are not the result of personal failure or poor choices. They are the predictable, documented, measurable outcomes of a system of interlocking barriers built over decades, maintained by policy and expanded by political choices that stands between underserved communities and the health care they need to and deserve. Today on Changing Trends and Times, we name the wall, we examine it section by section, the insurance gap and the Medicaid coverage cliff, the economics of being sick while poor, the geography of healthcare deserts, both rural and urban, implicit racial bias in clinical settings, language barriers that turn a doctor's visit into a dangerous navigation exercise, environmental racism, and the deliberate sitting of toxins in communities of color, and compounding intersectional weight of all of these barriers operating simultaneously on the same human being. This is a policy episode. That means the stakes are political. Healthcare access is determined by who holds power and who lives those power. Those power holders choose to prioritize. Every budget allocation, every Medicaid expansion vote, every hospital closure decision, these are choices made by elected officials, and the people who live with the consequences of those choices deserve to understand who made them and why. Today we hold the blueprint, we hold it up to the light, and every barrier has a name, every barrier has an author, and every barrier can be torn down. So let's go and let's talk about this architecture here, because there are so many people right now that are in underserved and marginalized communities that are really, especially those that are way out in rural urban areas, that cannot and do not have sufficient health care or facilities that are near them to help them. So let's start with the architecture of system barriers. And, you know, there's 7 things that I want to bring to your attention. The first is the insurance gap and who falls through. So let me just say this. We know that when people go to work, and most people say they want to take out the insurance because you need to take care of your family. You've got to insure your children. You got to make sure you're insured. If you're married, then you're doing it where you got, one of you guys decide who's going to pick up the coverage to carry the family, which would include the spouse. Now, as we talk about this healthcare situation, the thing that's so important about it is that, one, when most people that are paid, that are in these, these jobs where you're making just over minimum wage, but you're also trying to take out this insurance to keep your family covered. Now, you know that that is in itself a problem, and it's a problem because most people cannot afford to work that kind of job where you're being paid maybe $9-10 an hour. You're doing the family coverage for the insurance, and then you got to pay your rent, your utilities, you've got to buy food, you've got to prepare for miscellaneous, which you don't know what that's going to be. Now, let's just say there's husband and wife. One makes $10 an hour, one makes $15 an hour. Let's just say the husband is making them $15 an hour, and he's the one that's taking up the coverage for the family. The wife is doing the other part of basically having her check take care of the household. Now, they've got to be able to find somewhere, some kind of space in between in order to take care of the household. But they know that they got to have this insurance because they've got kids that are in the ages of 6 to 9. And so things happens with kids. Now, whether we talk about the short gap of this coverage, the gap is that they get these, they get you when it comes to the deductibles. And the deductibles are like very, very high, which causes a lot of people to not use the insurance, which means that there's no need to have the insurance. But if you don't have insurance, then you're going to get fined. So I want you to think about this. If you're in a place like in most southern states do not, and they are not a part of the exchange where it comes, where the medical exchange goes to where every state has to put their part into the bucket. When every state is a part of that exchange and they put their part into the bucket, that means that when the people in those states use their health care benefits, the premiums are very low. They're very low. But take these two things in consideration. We've had, political prowess where there's one side that has been trying to destroy the Affordable Health Care Act for the longest. And they just got the opportunity to tear away the last piece of that, via some of these other folk that allowed them to be able to go in and just cut the benefit. Okay. So because that's happened, and most states in the South especially, if not all, were not a part of the exchange, your premiums were very, very high. And your premiums are even higher now because when they cut that last part of the Affordable Health Care Act, premiums are up here now. So basically, it's like when you go to the doctor, your premiums are going to be at least, it could be as much, if you got to see a specialist, as much as $1,000 or higher. But they're in the hundreds of dollars, especially when you need care. So I want you to think about these things. It says approximately 26 million Americans remain uninsured, and Black and Latino and Indigenous Americans are disproportionately represented among that number. A disparity that is not incidental but structural. The 12 states that have refused to expand Medicaid under the Affordable Health Care Act, the majority of them southern states with large Black populations, have created what policy analytics call a coverage gap, a demographic trap in which residents earn too much to qualify for existing Medicaid thresholds, but too little to afford marketplace premiums and deductibles. Millions of Americans live in this gap, not because the ACA failed to account for them, but because their own state governments made an explicit political decision to leave them uninsured. This is not administrative oversight. It is a policy choice with a documented racial outcome, and it is one of the most significant drivers of healthcare inequity in the United States today. Not just wanting to prove a point, but just be factual about one thing, and that is the very states that are tearing away at the fabric of the country have caused and wanted healthcare to never be about your right. They never wanted to be about your right. They've always said it's a choice when it's a right. And so what we're finding is that when people are actually trying to take advantage of these very, very situations that they need so much, that was in place, that had millions of Americans covered, those same millions of Americans plus some are now uncovered, can't go to a doctor, and people are just dying and falling away by the wayside. Now, this is where, now I call this a choice. This is the choice is if you guys really think healthcare is that important to you, then you need to do your due diligence. You guys are going to have to go and you got to get out there and you're going to have to go vote. You're going to have to go vote. Because right now, the cost of premiums, health insurance premiums are so high on the rise and they cost so much that people are not, and I mean, people are not having the opportunity to actually do the things they need to do in order to keep themselves covered and to feel secure. Nobody's feeling secure. So let me just tell you guys another factor here. Point 2, and that is the economics of being sick while poor. Being sick while poor represents one thing, It means that you're just living above, you're living just above the poverty line, but not just being above the poverty line, you're still having to pay. And it costs so much for you to go to a doctor, to be seen, to be taken care of, because you can't afford it. And now they've made it. Now I'm talking about this administration up in this Congress and this Senate. They now have made it impossible for people to bankrupt or get rid of medical bills. That's no longer the case. They're going back to the pre-Affordable Health Care Act wave, where healthcare was this high and only a select few people could afford it. So when you're poor, you're living in a rural area, you're living in an urban area, that means that you're living more than 2 hours outside or away from a major healthcare facility to take care of you. Because the hospitals and the units that were out in those areas shut down. They shut down. Now, how do they expect these people to go and take care of themselves, to make their lives better, to live a quality life? That means that they don't care. But what's happening is that every day that passes and somebody's trying to go and take care of themselves in a hospital and they can't do it, the reason why they can't do it, people need to call that for what it is. This is political malpractice. It's what it is. It's political malpractice. And it's at an all-time high, and it's about as worse as it can get. But this is happening to citizens here in our country. It's happening to citizens here in our country. So let me just give you the in-depthness of this. For low-income and working-class families, healthcare is not a budget line item. It is an impossible calculation performed in real time against rent, utilities, childcare, and food. High deductibles, co-payments, and out-of-pocket maximums, even for patients who technically have insurance, function as a financial barrier that drive poor and working-class patients away from preventive care and into emergency rooms where they arrive later, sicker, and at a greater cost to themselves and to the system. The result is a compounding cycle. Poverty produces higher rates of chronic illness through stress, poor nutrition, and environmental exposure. Chronic illness without preventive management escalates into late-stage diagnoses. Late-stage diagnoses require more expensive, less effective intervention, and the resulting debt deepens poverty. The economics of being poor produce sicker people and then punish those people for being sick. That's crazy, but it's true. And I just think that, there's a comment here that I think that's worth, I want to ask this question. I'll put this on the screen. Christopher says, words needs opposite reaction. And when we say words need opposite reaction, I'm sure that means action itself. And so the action itself has got to come from the people. All of you guys that are feeling the effects of this, which is pretty much everybody. Everybody's feeling these effects. And the only way this is going to change is our representation has to change. Representation means that, you guys getting out to vote, going to city council meetings, holding community meetings, things of this nature, because you're going to have to hold people accountable. At this rate, and where things are going now in healthcare, with premiums being as high as they are, it is virtually impossible. And I'm just going to say it, put it in this perspective so you can understand this. We're now in the month of August. Today is August 1st, okay? The 8th month of the year. So that means that as we get closer to the end of this third quarter, that means that we don't have that many months. We do not have that many months before we get to the end, right? There's no way we're going to change this in 4 months. There's no way. It's not going to happen. But what does help is going to the polls and voting in November and getting all of those people out of there that contributed to this pain on each and every individual here in this country. That's how you remedy that. That's how you remedy that. You're going to have to get out there and you're going to have to go and vote, because I'm telling you, healthcare is about to go to a whole new level. And that level that is heading to is that even those that supposed to, quote unquote, that have more of a decent job that's above the poverty level, they're feeling those effects right now as well. But that's going to get even worse. And so what we're looking at pretty soon is that the haves and the have-nots. That's what we're looking at. We can't have that. We've got to do something about this. So my next point is, as I was mentioning earlier, geographic isolation, rural and urban healthcare deserts. Healthcare deserts exist in both rural and urban America, though the causes and contours differ. In rural areas, the closure of more than 140 hospitals since 2010, driven by financial pressures, Medicare reimbursement policies, and consolidation, has left entire counties without emergency care, primary care, or obstetric services. Physician shortages in rural regions are acute. The Health Resources and Services Administration designates thousands of rural areas as health professional shortages, as shortage areas. So in other words, they're saying those areas, there's just a shortage. There's no need to have those facilities there, and that for those people, if they're going to need this care, that means they need to come into the city. That's not a good thing, but it's a real thing. And this is one of those areas, that I think things has to definitely change, and it has to definitely get better. But this again is what has to be done by the people in order to make this change. The next thing is the implicit bias in clinical settings. And so when we talk about the implicit bias, the bias is more so to the point that, the points that are being proven are the reasons why there's no need to have healthcare facilities all over particular cities and states and their counties that are out in rural areas. That doesn't make sense. That does not make sense. So what has to happen is that as they're doing this, people need to, scream to the mountaintop or some kind of way. You're going to have to make you're gonna have to get these things to be focused on and let people know that you guys need healthcare facilities when you're out in one of those rural and urban areas. You see, advocacy is always good, but having those that are affected most makes it even better. So, therefore, the combination of the unity is what you're looking for. Decades of peer-reviewed research documents that implicit racial bias materially affects clinical decision making with consequences that are measurable and in many cases fatal. Black patients are statistically less likely to be referred to cardiac catheterization and less likely to receive adequate pain management. So, where we are there is when we're talking about this part of healthcare, it's like, again, they're saying that the more areas that you're in, it doesn't make sense to keep facilities in areas that only serve, as the way they make it, is a very minute number of people. So it's like saying you don't need a facility that's going to service 10 people. If you're going to have if you're going to have services, you need to have hundreds of thousands of patients. It's primarily what this is, the way this is being written up, and it's also the way they're saying that this is supposed to work. Give me 1 second here. So at any rate, I'll just tell you this. When dismissing people that are sick, dismissing people because they're poor, and not providing or setting up adequately services that are adequate to serve these people and to do what's right by them because it's the right thing to do, they are still taking away the very things that the people out in these areas need the most. They're still taking them away. And that is the one thing that I don't know, I guess it's kind of hard to explain this in the way in which it's needed. But what I am going to tell you is this, is that for those of you that live in those areas, I definitely would love to hear more of something from you. Because, this only makes the most sense. To me, it does. So let's talk about language and cultural barriers and the incompetence. With most people, when you're going into hospitals, especially emergency rooms, there's a barrier there, the language barrier. The language barrier is there, and it's there because the people that are going into these facilities for services, one, when they act as though if they're not understanding what if they're speaking language, and most likely this is like immigrants that I'm referring to, then these people, have more than a right, to be seen. But it's like there are some places that always throw up the barrier of language and keep these people out. Not a good thing. Not a good thing at all. So I just think that, we all have to get to the point of where we're actually paying our dues, but also we're living as best as we possibly can. And it's just unearthly to believe that this kind of discrimination still takes place. Environmental racism and the social determinants of health. Now, when we talk about environmental, in most urban areas, there's even out in rural areas, these health hazards are being created by major companies. And so what they're doing is they are actually putting um, they're actually putting facilities out in a way that's actually causing illnesses, airborne illnesses to people. And the newest thing that they're doing that's causing these problems are data centers. And so with these data centers that they're throwing up now, they're causing more and more problems than people could have ever imagined. I mean, more and more of them. So, with that being said, research consistently demonstrates that zip code is a stronger predictor of health outcomes than genetic code. Communities of color, shaped by decades of racially discriminatory housing, zoning, and land use policy, are disproportionately located near industrial facilities, petrochemical plants, solid waste sites, and areas with documented air and water quality degradation. This is environmental racism, the systematic citing of environmental hazards on low-income communities of color, and the parallel exclusion of those communities from the resources and political power needed to challenge those decisions. And so the great example is the Flint, Michigan water crisis. When they were putting the lead in the water in Flint, Michigan, that caused the illnesses of all those children. They did that themselves. And in the process of doing it, they refused to take ownership of it. They refused to do their due diligence and decided it was what it was. They didn't think it was necessary to do the right thing for those people and those kids in that county. What this is saying to me, and what it should be saying to each and every last one of us, is that when we're talking about folk that are sitting here and they are intentionally polluting areas, air, and whatever else that leads to quality of life, and this is done with intention, no one's being held accountable for it, and they may call it out. Why are we not doing the due diligence to protect citizens that are citizens of this country? I really think that this is a real serious problem. And this is what's leading to so many people, especially now, where people are coming up with all these different forms of cancers. It's the environment. The environment itself. It's already been polluted. And when you have a whole bunch of people that are so interconnected in smaller areas where, the box, it's not that big, it's a problem. So we have to do something about that. We have to do something about that. My final point to you guys is the compounding effect, and that's intersectionality of barriers. Let me just give you this data first. No barrier in this framework operates in isolation. The architecture of systemic exclusion is not a single wall. It is a system of interlocking walls reaching where each reinforcing the others, each multiplying the force of every other barrier the individual faces. Consider a Black woman in rural Mississippi. Her state has refused Medicaid expansion, leaving her in coverage gap. The nearest OBGYN is 60 miles away, and she has no reliable transportation. Her employer, a fast food restaurant, offers no paid sick leave. Her primary care provider, on the rare occasion she can access one, has been documented to underestimate her path. Her tap water has elevated levels of industrial contaminants. These barriers do not add up together linearly. They compound, they interact, they produce outcomes that no single intervention, no single policy change can resolve in isolation. Systemic barriers demand systemic solutions. This is not a talking point, it is a mathematical reality. That reality is that each and every one of those communities that are feeling those kind of effects will feel all of the drowning, all of the drainage, everything that is more so what they know will cause them a problem. But yet and still, most don't say anything either. So that's not like two wrongs make a right. But what that is that, when people are paying their tax dollars, they deserve the worthiness of like any other citizen in whatever city, county, and state you're living in. Treating them different doesn't make it better, it makes it worse. So what I want you guys to understand as we went through those 8 points is this. Most of you have health care. That's a good thing. Most of you are paying high premiums, which is a horrible thing. Most of you are trying to protect your family, which is a great thing. Most of you are trying to protect yourselves. That's a good thing. But for those that are trying to take healthcare away, that's a bad thing. And they're doing it by any means necessary. And people are still voting these people into office. I just don't get it. I don't understand. What is it that we're missing, and what makes one go out and do those kind of things? Because it really doesn't make sense. So I will tell you this. I'm looking for you guys to, to go along as we get towards this November time frame. And I'm just going to ask and hope that you guys get out and go vote, make your voices heard, and do what you have to do. Because where we are right now, we're at a point that it seems as though if nothing is going to happen right or correctly when it comes to doing what's right by the people, for the people. Let's do what we got to do, everybody. Let's go out and let's go vote, and let's change this thing. We will see you guys next Saturday for the final episode of Healthcare in the Underserved Communities. I will have an advocate as well as a guest that's going to talk more about lived experience as well as the advocacy work that he does. So, in closing, if this episode felt heavy, it should have. We covered a lot of ground today: insurance gaps and Medicaid exclusion by policy design, the economics of poverty that turn a copay into an impossible choice, rural hospital closures that leave entire counties without emergency care, urban neighborhoods hollowed out by consolidation and disinvestment, implicit bias that turns a doctor's exam into a site of harm, language barriers can predetermine the outcome of many, many lives. Ladies and gentlemen, I want you all to please do what's necessary to make sure that you're trying to protect your family as best as possible. Insurance premiums are very, very, very high. And with those premiums being as high as they are, they're going to cause many, many problems. And so the problems that this is going to cause are things that are going to be affecting so many people. And so my suggestion is that, think about and talk with your family about an enormous amount of things when it comes to healthcare, because you can't just tell somebody, okay, well, we mysteriously don't want you to be sick today. That doesn't work like that. But everybody's going through something when it comes to healthcare. And I want you guys to know that what you're going through is nothing new, but we got to do something about that, though, because we've got to change it. We've got to change this because there's no way premiums should be this high. There's no way that healthcare should not be affordable for each and every individual here in the United States of America. People that live north of me, up around the entire New England area, and that's northeast, going all the way back across the northwest. The majority of those people are taking themselves over into Canada in order to seek health care. I'm not telling anybody to do that, but I'm just saying that's what they're doing. And they're getting care at a much cheaper price than what we get here in the U.S. So I'm going to say to you, you guys be good. You guys do what you have to do. And you guys make it, go through your systems, check your systems, talk with your HR, talk with the people that you work with, talk with friends and family. Try to do what's necessary to try to put things in place in order to keep yourself ready for what could be. Because the inevitable is always here. I want to thank you all. You all have a great afternoon. Have a great weekend. We will see you guys next Saturday on Changing Trends and Times for the final episode of this docu-series, Healthcare in Underserved Marginalized Communities.